welcome.
The Pathology Innovation Collaborative Community is a regulatory science initiative that aims to facilitate innovations in pathology, as well as advance safety and effectiveness evaluation. The PIcc Collaborative Community aims to harmonise approaches to speed delivery to patients through collaboration in the pre-competitive space. The PIcc is open to all stakeholders, public or private, including but not limited to academia, industry, healthcare providers, patients, and advocacy groups. Meetings of this kind are an example of lawful activity under federal antitrust law because the focus of the meeting is on government action or policy, including the industry's responses or positions taken with respect thereto. However, antitrust monitoring is needed for companies' own protection since they are direct competitors meeting together. These meetings need to stay within protected subject matters and need to be monitored so that they do not stray off into inappropriate areas, such as pricing and price terms, sales and service territories for particular products, customers and customer territories, each company's individual decisions regarding selection of suppliers or customers, marketing plans and especially future marketing plans or new product offerings, other proprietary or competitively sensitive information. Today's meeting will follow the written agenda and there will be no discussion of pricing or other prohibited topics. If the discussion veers into those topics, we will terminate the discussion. If you have any questions or concerns about the propriety of the discussion, please raise it immediately, and we will take a break to determine how best to proceed. The Medical Device Innovation Consortium acts as the formal convener, and we will follow their conflict of interest policy. For additional information, we defer to our Code of Conduct and our website, www.pathologyinnovationcc.org. We look forward to moving the field forward.
Do that now. Let's see, how can I do that? Multiple participants can share simultaneously. So can you try it, Eric?
So theoretically, Esther, you have to unshare, and then once you unshare, then Eric can share.
Yeah, I've been able to grab it. So this is the way I like to explain to people on how it works. And oops, hold on. Yeah, so essentially what Ben is saying is it's easier to engage at the association level, which is the analogy I like to use is a sports league, right? So it's kind of the commissioner's office level because there's actually 36 independently owned and operated Blue Cross Blue Shield plans across the US. The reason why people try to access the Blues is that the Blues system covers 1/3 of the US population. So 109 million US lives are covered by some form of Blue Cross Blue Shield insurance. So Ben's point is that each of the local plans does have their annual priorities. And so instead of you trying to reach out to all 36 plans and trying to find out like who to talk with, if you're able to access the association level to find out, it's a lot more centralized there. So that's what the main reason I wanted to share that with you. So this is kind of the ecosystem that Ben and I worked in or lived in for 3, 4, 5 years.
Thanks, Eric. Fantastic. So just picking up from where Eric left off, so we do have those 36 plans. I can't speak to you in detail on those 36 plans, but I'll talk to you about like the top 3 that I'm pretty conversant with, and you can ask me questions about these 3. So one would be Highmark Health that has Vital Innovation, which is where I came out of. So we have that. We've been running that for, I want to say, about 3-4 years. It's not necessarily focused on pilots, but you could call them pilots. How we sort of distinguish pilots versus what we're testing and learning, what we call ours is a test and learn. So we kind of think about pilots as I don't want to use generic, but we kind of think about it as something that any of the other plans can do. But because Highmark Health is what you call an integrated delivery network, both owning the payer arm as well as a provider group or health system, we find ourselves in a unique position where not only can we seamlessly bring the innovation in, but we can garner the clinical support required from our provider system to support, one, the early evaluation of the solution, as well as gain early commitment that if we bring in the solution to test, if it is successful, we will drive forward, execute, and move towards a coverage decision as well as utilization further down the line. And so, we call our system a test and learn system. There are two other Blues that I'm aware of that run a model quite close to this test and learn system, and that would be Anthem's Healthcore. So it's a group called Healthcore. They used to be internal to Anthem, but I think now they are a subsidiary. They still linked to Anthem, but I think they operate slightly independently. And the other one would be Care First. So that's another Blues plan in the Washington, D.C. So it's a DMV, Washington, D.C., Maryland, Virginia. Just making sure you can hear me. I see my connections fading a little bit.
Yeah, you broke up for like a few seconds. So it's
okay. All right. So did you hear Care First, located in the DC, Maryland, Virginia area? Did you hear that?
Yes.
Okay, fantastic. And so they've got a group called HealthWorks, and HealthWorks is focused around, again, very similar. They can test and learn solutions. They're not an integrated delivery service, but they have a strong partnership with one of the health systems in the area. So they're capable of doing the same thing. All right. So these are the three major players, and how these three players differ is, quite possibly based on the business model, right? And so I'll see about business model, but let's talk about maybe some of the goals of these plans. So from a Highmark perspective, my goal was to identify what I'd consider high impact innovative solutions that deliver significant impact on both clinical metrics,
Now we're losing you, Ben. At least I am losing you. I don't know about the rest.
Metrics as well as the patient. Oops. All right. Can you hear me?
Now you're back. Yes. No.
Okay. If you lose me again, just like flag me, and then what I'll do is just dial in. Does that make sense? Or actually, you know what? Let me cut the video feed, and hopefully it's a stronger. Sorry about that.
Yeah.
All right. Is that better?
Yeah.
All right. Fantastic.
Yes.
Sorry, I'll just cut the video feed. Okay, perfect. So talked to you about the goals. So, Esther, I like what you mentioned in regards to like ROI. That's one of the big things for us is being able to identify or, the position our stakeholders to understand how significant are. Am I out? All right, let's do this. Just give me.
Cutting in and out. Yeah.
Just give me a minute, and I'm just going to dial in. That tends to be a stronger signal.
And then maybe hi, Laura and Joe. Maybe you could also quickly say hi to Ben when he's back.
Hi, Ben. Hey.
And Esther, for the other two companies that Ben mentioned, I just put the link in the chat so you could just pull them up, the Healthcore and then the HealthWorks as well.
Yeah, great. Thanks.
How is everyone as we're waiting?
Good.
Yeah,
Yeah.
good seeing you.
Likewise. It's good to be back in Boston.
How
You
long
are?
were you away for, Esther? Because you were traveling around in a couple of different locations, right?
Yeah. Yeah, I've been in Europe mostly 2.5 months almost. So yeah. So it's good to be back. And you're just still working from home?
You're asking me? I'm
Well, you're not working from home. You're always at the at the hospital, almost always. But you, Eric, is Pattaya still working from home, or?
Yeah, Pathai is still working from home. I think people have flexibility, but I think still right now, majority of the folks are still working from home.
Okay. Yeah. I see.
I see a number that's connecting, right? Assuming that's Ben. Is he on mute? Let's see.
Looks like it. Nope. I'm gone.
Let me send a message.
Thanks.
Hello, can you hear me?
Yep.
Yep, we can hear you, Ben.
All right, fantastic. Sorry about that. I think this is going to work a lot better. Let me know if there is I would suspect there's a slight delay, but let me know if there's if you're having any problems hearing me. All right.
All right.
Fantastic. So I'll pick up from where I left off. And so I think I was remarking that around ROI, that's something that's extremely important as we think about these sort of test and learn programs. And so that's something that we look to work with the innovation company or innovation partner to ensure that we're able to prove out the ROI, right? And so that tends to be something we collaborate on, but it begins at the early evaluation of the solution. So with that said, just talked about some of the goals. I'll just repeat some of the goals for our program. For the VITAL programs, and the goals were around like the clinical metrics, like how significant is this innovation going to be in moving clinical metrics forward? The economics is very important as well, and that's where we talk about ROI. And the third piece of it is really around experience. So for us, one of the biggest challenges for us is that we understand that the healthcare system is broken. Be it our pathologists, our clinicians are constantly struggling to keep up with, be it the required documentation that's needed. And so any sort of tools or solutions that we can bring in that relieve them of some of these, I would say, low-level responsibilities is definitely a bonus to us. And so for us at Highmark Health or with Vital Innovation, we always looked at what significantly changes the experience for the clinician so they can begin to practice at the top of their license versus being inundated with documentation that can be resolved by technology. So any questions in that? I'm happy to take a question. If not, what I'll do is just proceed to, again, some of the focus areas and then talk about some of the business models that actually differentiate the three programs.
Yeah, Ben, I'm wondering if you can expand on that last goal that you just were describing a little bit. And some of this may just be I'm sure is just a lack of my understanding, but I was under the impression that innovations that purely say we make things faster on the clinician side don't necessarily merit reimbursement just because it makes things maybe more efficient or et cetera for a laboratory. But it sounds like what you're saying is your goal is actually to improve the experience for the clinician. So can you maybe like explain to me why there might be a disconnect there?
No, that is a fantastic question, Laura. I think you hit the nail on the head. So would we typically approve a solution and provide it coverage based on the fact that it improves the efficiency of a clinician? Not necessarily. What we would typically look at is to say, out of these three metrics I just mentioned, can the innovative solution move the needle significantly on 2 out of these 3 metrics? So to answer your question directly, when we think about the patient or the provider experience that's being, that we are now driving efficiency around, we'd also want to make sure that the clinical metrics are also moving forward. Now, in the case that the clinical metrics are not significantly moving forward, each health plan has the ability to make an independent decision to say, we see enough shift on the economics, we see enough shift on the experience, we may not worry too much about the clinical experience if we see significant shifts around economics as well as experience. But that's a decision individual plans will make. If you look at it from an association level, then you would definitely want to see significant clinical metrics moving forward. So I think you're spot on there, Laura. It's very hard and it's very challenging to get coverage decisions just based on efficiency. It's usually a significant challenge. But if you can show efficiency and the economics, then I know from my previous experience at Highmark Health that we will consider covering a particular solution. Does that help?
Right. No, that's extremely helpful. Thank you for clarifying.
Fantastic. So as I previously mentioned, I'm going to talk about some focus areas, as of, and I'll, just date myself here, I'll say as of 2021 Q1, while I was still at Highmark Health, the major focus areas for us were around oncology, which I think definitely falls well within the pathology space. Again, some of the typical diabetes, CKD, cardiovascular, these were major areas of focus. Now, quick caveat is that these focus areas do change on an annual basis, as I mentioned earlier, and the best way to get an update on a particular plan's focus area would be to engage with the association, as Eric showed the image of all the different plans. What I do know is that oncology remains a staple. If I were to think back to the 3 plans that I mentioned to you now, so be it the Anthem Healthcore, Care First HealthWorks, they all had oncology on their roadmap this year, and so there's a strong case for looking at digital pathology as well. So that's what I would say around focus areas. Next, I would talk through business model, and then maybe talk you through timelines and our process. The process will be different for each one of the different companies, but they'll generally be reasonably similar. So, and when I talk to you about business models, Esther, I think this relates directly to your question of as we think about coverage decisions and running these quote unquote, I'll call them in general here on this platform, pilot studies, how do you manage the costs associated around this, right? And so this is where it becomes really interesting because there are 2 major pathways. So when you look at the work that we were doing at Highmark Health around vital innovation, what I would say is that vital innovation differed from Healthcore and HealthWorks because we were more of what you'd consider a commercial offering. And so it was a fee. So there was this upfront fee that needed to be paid if you were accepted into the program. And once you were accepted into the program, there was the upfront fee. And as we processed through the first stage of the program, which is the opportunity assessment, the second phase of it, if we were convinced of the impact of the solution, then we would actually look at how we cover a significant part of the costs for the additional testing. So when we think about additional testing, we're talking about prospective testing. How do we recruit the patients? How do we pull them from our provider network? And how do we test this solution over a 12 to 18-month period? And so we'd cover the significant costs or a majority of the costs associated with that. Now, how does that differ from other organizations, so be it Healthcore and HealthWorks? Healthcore and HealthWorks have a different business model. As of early this year, it may have changed a little bit, but Healthcare and HealthWorks were more focused on ensuring that your solutions aligned with their narrow strategic objectives for the year. And if it did align with those objectives, what they looked to do was to actually look to invest in your solution. And once they'd made the investment, what they would do is either request for like equity or equity royalties. It would be a different, depending on what the solution was and what the financials behind it, where they would consider whether they wanted just equity or whether they wanted some sort of grants. But, the difference between these two groups was we were more of an upfront sort of commercial model. And with the other two groups, they were more about taking equity or investing within your innovative solution. In our case at Highmark Health, we also considered the investing opportunity, but it took a lot of time for us to get approval internally from our stakeholders to actually make that investment. So we actually had to put that on the back burner. So depending on your financials, if you do have, and I would say that these are nominal costs, but I'm sitting on the other side of the fence. For us to run what I would consider an opportunity assessment was somewhere between like $60,000 and $80,000. And that was, I want to say that's maybe a 12-week process. So I'm kind of going into the process now. And then as the significant test, which is a prospective test, came along, what we would do would be we would actually cover the cost of deploying your solution within our ecosystem. So assuming the pathology tests were costing, or digital pathology was costing, I would throw out a number. I don't know what it costs today, but I would throw out a number and say if the costs were about $500 to $1,000, we would absorb that cost for the number of patients that we had, that our power analysis had suggested that we would need in order to prove, significance within that test. And so we would basically cover the upfront cost, but we would charge you a nominal fee to ensure that, and the fee wasn't really about profitability. It was really about just making sure that the innovation company was fully engaged during the testing process. So I will pause there for a second. Maybe any questions around business model. I'll probably make one more comment after any questions about business model, and then we'll go into time frame and process. Any questions around business model?
Yes, I have a question. So what if the business case for this particular technology is largely built around cost savings? And I don't mean cost savings on the insurer side, but cost saving on the provider side.
Mm-hmm.
So,
That's a fantastic question. That's a
So the technology that we're talking about is basically increasing the pathologist efficiency. It may save in external consultations. There may be reduced cost in, let's say, internal glass slide handling and real estate savings from storing it on-prem. So these are all arguments that have been made for this particular technology that are gains in terms of, let's call it efficiency, cost, and convenience, in lack of a better term. But ultimately, when it comes to the, let's say, accomplishments for the return of investment, these are all reducing cost ultimately, I mean, they cost the department, but they're reducing cost in another way. But how could that be made into an argument for payers other than resulting in reduced reimbursements? And then, the upfront investment has to be still made by, in this case, the provider side. So I think that's a unique setting that we haven't encountered, because the points you're making, if we had, absolutely dead-on overall survival benefits, or if the clinical value proposition would be 100% clear in terms of health outcomes, we would present that, just like you said, and the approaches are existing with payers. But here we have sort of the opposite, where the value proposition is almost the inverse, where there's an upfront investment that may lead to a reduction in cost, but they cannot manifest initially in a reduction in reimbursement or in no coverage in a way.
No, I think that's an excellent question, and that poses its own sort of unique challenges. What I will do, sort of answer this slightly off the record, and what I would do is put myself in your shoes and say, if I were sitting in your shoes, my strategy would be, again, as you've mentioned, there's some significant upside for the provider, and maybe not so much for the payer. And in my experience, we've had solutions that came in with the same sort of propositions where the value was really on the provider side. And the approach that I saw that was successful and we were able to collaborate with the innovation company was really being able to approach the provider and actually sell it to the provider. But you would have to be selling to a provider and make the provider your clinical champion or your champion coming back into the payer system. And so if I were thinking about targeting, I would be targeting, IDNs, because the relationship between the payer and the provider in an IDN system allows for the payer to overlook some of the additional costs, upfront costs, and the fact that, reimbursement that, they don't look, the payer in the IDN system will overlook that reimbursement challenge and say, this is almost like a way to appease my providers, because it's all a give and take, right? And so we may be able to deliver some value, and it may cost us a little bit more as a payer to a closed provider network, with the exchange that, it could be within a different part of the same provider network that we are actually making more gains, if that makes sense to you. And so the trick here is, and I hate to call it a trick, but I mean, the path forward here is to say, how do you make the provider, the clinical champion, actually walk across in an IDN? So my focus will be IDNs, and walk across in an IDN to actually position for your solution.
So I like the idea, the approach will work. The problem is that we're not providers of direct patient services, but we're providing services to other providers. Thereby, we're one step removed of directly influencing an IDN, let's call it business case, or facilitate that structure. The second point there is also that in an IDN, the cost would be deferred, of course, to all participating parties. The closest similar structure would be, let's call it a hospital information management system or an electronic medical record. That definitely ties together in an IDN, to share information that has a large upfront cost, and you can't get reimbursed for an electronic medical record, but it enables certain things. The problem here is that in a comparison with the electronic medical record, it orchestrates and documents a lot of the individual procedures and performance measures of the providers, so there's like an inherent interest to have that. The inherent interest in the technology that we're talking about is an add-on to an already established system without having any reimbursement codes for it. So, of course, in an integrated delivery network, people will ask, well, what is the value added? And then we're back to square one. Then it's basically the network asking, and we get to the point of, okay, well, you can shuffle cases around, you have the additional benefit, but that is a cost reduction for the IDN. So it's, as you mentioned, I like the word appease there. It's like getting a couple of people on the same page, but it's definitely a very, very tricky setting of implementing this.
No, absolutely. It sounds really interesting. I think what we could possibly do is, maybe on a future call, maybe you can share some additional details, and I'll help you think through it. I know that from my previous engagements with, playing, and that's why I say, I've always had to play that balance, the middleman between the provider network, our provider group, as well as the payer side of the business, and sort of appeasing both sides. And, my experience has been, there are opportunities to do it, but I'd have to look at some more details on your specific solution and, sort of think about it. And maybe even pull in a couple of colleagues where we've done this before. So, but again, like I say, I totally respect what you're saying, where you're one step removed. So it does make it adds a certain level of complexity where your ability to engage, or your ability to influence that provider, is a little bit more difficult. So.
Also, I'm being mindful of time. I don't know how everybody's schedule is, but we're having 1 minute left.
Ben, if available, it would be great to hear from you, maybe in the next meeting, if you have another 5 to 10 minutes to hear about the timeline. I didn't mean to cut into the timeline, because that is really important, and to be aware of the time scale here, but I don't think we will have time today. But it would be really, really interesting to hear that from you, if you're willing.
No, absolutely. What I can do is I can actually drop like some quick notes here in the chat, and maybe that sets up for a conversation next time. Give me a second. Let me just drop this in, and at least you have it. Where are we? Okay. All right. So sorry, the format's all over the place, but maybe this is helpful. So when I look at, when we talk about timeline, we're thinking about 24 months from the day of engagement. So from the first day you pick up the phone, or I pick up the phone, and we get engaged, and you get into my CRM system, 24 months up until the coverage decision. What typically happens where we have, where there's significant time spent within that timeline, is really around where I've noted as prospective testing, as well as medical policy review, as well as decision. Those are the big bucket areas. The prospective testing can take anywhere from 9 to 12 months. Then coverage decisions, review of the data can take, another 3 months. You can also estimate that sometimes, because we're also leveraging claims data, sometimes we're waiting on claims run out. So if we're, depending, the prospective test can be 9, 12, or maybe 13, 14 months. So that's really where the big chunk of time is. The upfront evaluation, we can probably do that in the first 90 days, deliver an opportunity assessment in another 90 days. What I can do is sort of, if any of these terms are not very clear, I can kind of walk you through it on the next call or something like that, if that's helpful.
Yeah, I think that would be fantastic. It would be great if you could do that. Yeah.
Okay, fantastic.
Yeah.
All right.
Can I then align with you, Ben? Because I know we usually have every 2 weeks a call, but I know in 2 weeks from now we have pathology visions, so some of us will be there and cannot join this call. So might it be good that we do it the week thereafter or the week thereafter? I know that's taking a long time, but would that work for you?
No, I think that should be fine. I'll just confirm those dates once, if you send them to me, I'll just confirm those dates with you. No problem.
Yeah, okay. We'll stay in touch. I see that everybody's have to jump off. So thanks so much, Ben. This is really helpful. learned a ton. I hope you learned something from us as well. And yeah, I'll reach out to you soon.
Thank you, Ben. Thank you.
Absolutely.
Thanks, Ben.
Thank you so much. Have a great one.
Thanks. Bye.
All right, bye.